It's always good when your students come back. That means they don't hate you sufficiently to not return. So I'm excited to be here. It's a little different. I was telling the first group that traumatic brain injury isn't typically what you think of when you think psychological trauma, right? I mean, typically you think the more PTSD-related things, but traumatic brain injury has huge emotional components that go along with it. So ultimately you'll see it's very relevant while slightly different than what the other workshops may be. Hopefully you find it useful and helpful. And can everyone hear me okay? Okay. And I won't use the microphone if that's okay. So what's a traumatic brain injury? Traumatic brain injury typically is a result of an impact or blow to the head. Okay? This impact can result in jarring of the neural structure and ultimate changes in consciousness. And that's the big diagnostic piece. You have to have some alteration in consciousness to be diagnosed with a traumatic brain injury. Now, in a concussion, that can mean dizziness, it can mean nausea. It doesn't have to mean unconsciousness. It's just an alteration in consciousness that goes along with it. Okay? So we'll do a status exam, a sideline exam, something in a hospital. We'll see exactly what's going on with their head injury and then move on to treatment from there. Okay? So who does traumatic brain injury affect? Well, it affects a lot of us. Current estimates are about 1.7 million people per year in the United States alone. So there's a huge public health need for people looking at traumatic brain injury. Of those 1.7 million, about 52,000 will die as a result of their injury. 275,000 are hospital, but here's the big one. About 1.4 million people are treated and released from the ER in the United States due to head injury each year. This is where you guys come into play, right? Psychological services. Huge part that impacts therapy. Even if you're not a neuropsychologist or you're not in a hospital setting, you will see people who have had a traumatic brain injury or concussion that's influencing their current performance, their current day-to-day activities, because of how staggeringly high these numbers are right now. Okay? And the effects of TBI are huge in terms of lost productivity. About $60 billion per year lost in estimates from the year 2000. What do you guys think it is today?
Worse of all the beds.
Yeah, I mean, the veterans are coming home. Vietnam veterans who have had TBI are at increased risk for dementia. We're starting to get that group coming into the VAs, and so there's a lot of interesting factors that make TBI a really big public health difficulty. So how do TBIs happen? Well, the number one way that TBIs happen is through cars. We didn't evolve well for cars, and so you get in a car, every time you're in a car, you're at risk for a head injury. How many of you want to walk? Well, don't walk, because the number two reason is falls. Okay, so number one is going to be transportation, motor vehicle accidents, boating accidents. I saw a case who combined boating with alcohol. He was drinking, decided to do a handstand on his boat while it was going down a river. Boat ran into a pier. He had a severe traumatic brain injury. Okay? Don't combine motor vehicles, boats, anything with alcohol. It's a bad choice. Falls are number two. This is mostly due to the elderly and the really young. So ages 2 to 4 experience a lot of falls, and ages 65 plus experience a lot of falls, enough to make it the number 2 reason for head injury. Okay. Number 3 is assaults or guns. Any individual who has an open head injury would get classified as a traumatic brain injury. So you get a gunshot wound to the head, you get an assault with a gun or with a baseball bat, that's going to be lumped with a traumatic brain injury. Or fists. Fists could even lead to traumatic brain injuries. We call that boxing. And that would actually be lumped under number 4, which is sports and recreation. Okay? Now, sports and recreation injuries are interesting. What sport, this one's obvious, has the most head injuries? Football. Let's break down males and females. For females, what's number 1? Soccer. Soccer's number 1 for females. Why is that? Headers is incorrect. The reason is contact with other players in the ground most of the time. So when you see people going up for a 50-50 ball, they'll tend to hit each other. One person often falls back. You'll get a whiplash type movement, so they'll strike the ground with their head. Or you'll get an elbow to the skull, elbow to the head. So soccer's number 2 in females. Or number 1 in females, number 2 overall. Interesting research that's coming out suggests that neck strength is a big predictor of concussion in female soccer players. Females with lower neck strength are getting concussion at higher rates than females with higher neck strength. So, kind of note to all the soccer parents out here, you should have your children doing neck strengthening exercises, because then they don't get the same whiplash motion. They can actually stop it a little more if they have stronger necks. So soccer coaches should be doing neck strengthening, parents should be doing neck strengthening to help prevent concussions in that group. What do you guys think is number 2 for males after football? Church basketball. Possibly. Number 2 is actually hockey. Ice hockey is number 2. Number 3 is wrestling. Number 4 is rugby. So a lot of those contact sports involved there. So in children then, we see that those that are younger than age 14 tend to be injured from falls or from sports would be what the other is here. Whereas after age 14, look at the preponderance. It tends to be motor vehicle accidents in a huge way. There's something not really wise about letting people the age of 16 drive. Okay? When do our frontal lobes finally develop?
25.
And research shows between 24 and 25 is when our frontal lobes actually develop. Our frontal lobes are in charge of inhibition, decision-making, organization, and planning. So we're taking 16-year-olds who don't have good frontal lobes and putting them behind a large hunk of metal that moves. Okay? Bad choice. High levels of head injury. Okay? Right there in that 16-year-old group really drives that. Okay? And in fact, it's so high that traumatic brain injury is the leading cause of death and disability for children and adolescents in the United States. Number 1 is traumatic brain injury for kids. So it's a big public health problem. It's especially a problem for kids because it's associated with lifelong difficulties, both emotional and cognitive, that we'll talk about through the course of today.
Where for adults and children who like tumors or some other kind of health issue?
As far as in relation to traumatic brain injury, so they tend to be much lower in prevalence, so we don't see tons and tons of them, and they tend to be much more precise. So if someone excises a tumor, they'll get a specific location. You can get some broader deficits, but not as broad as you get with the traumatic brain injury. Good question. So these 2 statistics people find interesting. For children, those under age 4 tend to have the most emergency department visits. Why is that? They're playing, they're falling, but is it really the kid's fault that they're going to the emergency room? No, this is called hypervigilant parent. I have a 3-year-old. The dude has a motor like you wouldn't believe. Okay? He's banging his head on everything all the time. And if I wasn't a neuropsychologist, we probably would have been to the ER a few times. Okay? But you can kind of see when it's a concussion versus not. But if you have no training, parents will bring you in. So that drives that younger one. 4-year-olds go to the emergency room the most, but children 14 to 18 are hospitalized and die the most. What's the reason? Cars. Yep, they're starting to get into car accidents between 14 to 18. So you get more hospitalizations and deaths. So who's going to have the TBI? Well, one of our biggest predictors of TBI is maleness. Increased levels of maleness means increased levels of TBI. Okay? Being male tends to be associated with more risk-taking behaviors. Faster driving often is associated with it, and then more playing sports that are more dangerous. So being male is one of our biggest predictors. Ethnicity is controversial. It's more tied to socioeconomic status. So people from lower socioeconomic status are engaging often in more risky behaviors, less supervision, less parental time, so you get increased TBI rates there. Okay? If you've had a head injury before, your likelihood of having a second one goes way up. There's 2 reasons for that. One is because your brain becomes more vulnerable. You've had insult to the brain, it's more vulnerable to contusion and injury the second time. Think Steve Young, right? He had his first concussion, first time was in the NFL, but then boom, boom, boom. A series of concussions, 6 over 3 years, because his brain became more vulnerable at that point. Okay? Second reason is because if you had a TBI, you were engaging in behaviors that led to a TBI. As we know, the best predictor of future behavior is past behavior. And so people that were engaging in things that led to a TBI are probably still going to engage in things that lead to TBIs. So those are the 2 reasons why if you've had a TBI, you're more likely to have enough of these. Okay? And then other things like if you have a previous psychiatric diagnosis or attention deficit or other learning disabilities, all those things are predictive. If you think ADHD, there's a big literature on orthopedic impairments. We know they have more broken bones. We know they have more accidents. They also have more concussions. It's part of the game with ADHD, just because they're not attentive to the environment, more impulsive, more risk-taking behaviors there. So what you guys are going to see is you're going to see medical records, right? You're going to have people coming in saying I had head injury. You're going to get medical records to try and look at it to determine how that TBI is going to affect functioning. So there's a few things you should know about TBI measurement. Okay? The most common measure of traumatic brain injury severity is called the Glasgow Coma Scale, or GCS. The Glasgow Coma Scale ranges from 3 to 15, with lower scores meaning more severe injury. So a 3 is the worst possible injury you can have, and a 15 means you were conscious, you were speaking, you were moving, you were pretty much fine at the scene. Okay? So 3 to 15, 15's the best, 3's the worst. You can see here that 13 to 15 is a mild injury, 9 to 12 is a moderate, and anything between 8 and 3 is going to be severe. Okay? So how do we measure GCS? Well, there are 3 main areas of the Glasgow Coma Scale. The first is motor movements. If after a head injury you can obey commands, they ask you to stand up, they ask you to move, you can obey those commands fine, you'll get a 6 on the motor part of the GCS. Okay? Otherwise, we start to induce pain to see how they move. We do the pain in 2 ways. One is we'll do deep nail pressure. You guys ever put your pen over your thumbnail and push down on it? It hurts like crazy. So we'll do that to induce pain, or we'll do what's called a sternal rub. The sternal rub, we'll take our knuckle and we'll rub the sternum. People really love you when you're the one in the hospital rubbing their sternum. If they'll swat at the pain and they can localize the pain, try and make it stop, they'll get a 5 because they can localize it. If they're just responding generally with motor movement but can't localize, they'll get a 4. Down to the point where they won't respond at all, that would be a 1. Okay? Verbally would be oriented, alert, they're fine, they get full points, a 5. If they're confused or inappropriate or incomprehensible, the score goes down. And then similarly for eye opening, if their eyes are open spontaneously, it's a 4. If they localize when you say, hey, and then you try and get their attention, if they open their eyes, they get a 3. If they do the pain, the sternal rub or the deep nail pressure, and they open their eyes, they get a 2. And if they just don't open their eyes, they get a 1. So that's why 3 is the lowest score, right? Because the lowest you can get on each scale is a 1. That's why it doesn't go to 0. So I feel like I had someone come in and say they had a GCS of 0. And I smiled. Okay. Yeah, it doesn't work that way. Other things we look at that you can get from medical records. One is length of loss of consciousness. The longer an individual is unconscious, the worse their outcomes tend to be. So if they have days to weeks to months, you're having a very severe injury. When we're talking about concussion, we're talking 0 minutes to 30 minutes. That's a mild head injury. 30 minutes to 24 hours is a moderate head injury. 24 hours and beyond for loss of consciousness is a severe injury. Does that kind of help you get your head around those levels? There's a problem here, though. Nowadays, when people get a moderate or severe head injury, we need to get them resting. And there's some research suggesting if we can cool their body temperature, then they'll have better outcomes. So in almost all cases of moderate and severe head injuries now, people are getting put into medically induced comas. So we don't know how long they would have been unconscious because it's medically induced, right? So LOC, loss of consciousness, has become not as good of a predictor because it's often medically induced now. So what's a better predictor is time to follow commands. How long does it take them until they're lucid enough to follow 1- and 2-step commands from a therapist? So what you guys should be looking for when you get a record or a neuropsychological report, look for that Glasgow Coma Scale. Lower scores are worse. Look for time to follow commands, or even LOC, loss of consciousness if they have it. But that should help you get a feel for where they're going to be as far as severity levels. Questions on any of that? Yeah.
So is the theory behind the reduction of temperature and induced coma to reduce blood flow?
No, it's actually to reduce swelling. So when you get swelling, you'll get it pushing against the brain, and then, or pushing against the skull, and you can get tissue loss.
Okay.
So good question.
When is this evaluation done? I'm assuming with all this time, it's done in the hospital?
Yeah,
Do it on the
great question. EMT. So if you have a car accident, the EMT will do it on the scene, and then you tend to get it done in the emergency department as well. So you'll get 2, and we typically use the lowest Glasgow Coma scale as our indicator of severity. So they might be a 15 on the scene that had a brain bleed, so they'll slowly lose consciousness as they get to the hospital, and then there are 3 at the ER. So they've gone from a 15 to a 3 in an hour, right? We'll use that 3 as our severity indicator.
You didn't mention memory loss at all. Is that just part of the disorientation?
Oh, we're coming, baby. We're coming. Big time. So, post-traumatic amnesia is what you're speaking of. Post-traumatic amnesia is another good predictor.
Is it just post-traumatic amnesia due by choosing not to remember, or is it actually injury-induced?
It's actually injury-induced.
Yeah.
Big time.
Not just a physiological protection,
Yeah.
but a...
Yeah, so it's that, so you're using it almost like a repression or dissociative kind of memory. That can happen, but it's pretty rare. I'm going to show you some slides of hippocampus in a minute and some temporal lobe areas. You'll see that that's the #1 area that gets injured in head injuries. So very common. Good question. Okay, so what happens then? Let's talk physiology for a second. Some of these slides get a little gnarly. Hopefully no one has really queasy stomachs. There'll be a little bit of post-mortem brains coming. We all cool with that?
Bring it on.
That was the trigger warning for anyone who needed it. So closed head injury then, you'll see that closed head injury where the brain hits the skull is the #1 type of head injury. Open head injuries where you get a gunshot wound or an assault tend to be less common, but still are considered traumatic brain injuries. So what happens then in a closed head injury? Well, there are 2 main sites of injury. One's called the coup and the other one's the counter coup. The coup is the site of initial impact. So if you're driving down the road and a semi-truck changes lanes and you hit the semi-truck head on, you're going to get a coup injury as your brain goes up and slides into the skull because the skull will be stopped. We call that acceleration deceleration. You're suddenly decelerated as you hit the skull. Then, just physics, you're going to recoil, right? So you get an injury at the coup site, which is the primary injury, and then you get a counter coup on the opposite side of the injury. And that can occur at any angle. It could be coup, counter coup, it could be coup, counter coup. It can occur at any angle, but you tend to get a primary injury site and a secondary injury site with almost all TBIs. Okay? The other thing that tends to happen is you get these rotational forces. So this is obviously a post-mortem brain. What happened in this person is they were in a car accident. The spinal cord works to tether the brain here, right? And if you get severe rotational forces, you can actually get the top of the brain to shear and rip. And so this person actually had the top of their brain rip off their temporal lobes. It resulted in death. They didn't really feel it. They were dead. But can be pretty gnarly. For most people, it doesn't result in a full shearing. It normally results in just a stretching of axons and small microbleeds. That stretching, we call it diffuse axonal injury, can often be as severe as the primary or secondary injury, but is often not accounted for because we don't see it as well on scans. Okay? So remember that you have the primary, the secondary, as well as the shearing, the pulling apart of those axons from rotational forces. So cars that get in rollovers, that get in spinning accidents. Someone in the morning session or the earlier session talked about a tubing accident where the person got flung and then had a concussion without ever hitting their head. Yes, you can get a concussion without hitting your head from those rotational forces. Does that make sense to everyone? So in evolution, we didn't really evolve to be car drivers. Right? If you look at our skull, we have 2 main areas. This is the base of the skull. We have 2 main areas that hold the brain matter, the anterior fossa and the middle fossa. The anterior fossa sit right above your sinus, right there. That's called the sphenoid sinus. That sinus has bony ridges that stick up from it. So when you have a head injury, your brain's sitting on cerebrospinal fluid, which is just like, it's like gelatinous water, essentially. So as your head hits something, your brain moves across that. And if you have a severe head injury, it'll smash into the front of that calvarium, shearing on those bony processes that come up. So you tend to get the most injury in the frontal lobes, and the second most, look how sharp that is right there. You tend to get the second most, this holds the temporal lobes. The temporal lobes have the hippocampus, which is associated with memory, learning. Okay, so memory and new learning, frontal lobe functions like inhibition, okay, planning, organizing, and personality, those are what are going to take the biggest hit. In fact, if you look at, this is from a study showing multiple overlapping TBIs, the most common sites then are going to be those ventromedial frontal lobes and the temporal lobes. Personality, organization, planning, inhibition, memory. Okay? That's what's going to take the biggest hits. The third biggest area that takes a hit are known as the olfactory bulbs. The olfactory bulbs are right here. You can see them in this drawing. One's there and one's there. And they're literally what slide across that sinus as you have the injury. So individuals with traumatic brain injury tend to have decreased smell abilities. Okay? We call it anosmia. It's very diagnostic of traumatic brain injury. And interestingly enough, from a differential diagnosis perspective, can mimic symptoms of depression and anxiety. Why? Well, you can't smell your food. So, do you want to eat? Not as much, so you stop eating. You end up having weight loss, you end up having lack of appetite. What does this sound like? Depression, right? So that should be part of your differential diagnosis when you see people with traumatic brain injury. Assess their smell, see if their smell changed and how that change in smell has affected their eating behaviors and sometimes even their mood and motivation. Okay. A couple post-mortem brains here, just to give you the same idea. Here are the olfactory bulbs in this person. They're not where they're supposed to be. They're way over there. Temporal lobes, frontal lobes. You can see the olfactory bulbs better here. Look at that contusion right on the olfactory bulb. Right there. Along with the other contusions, obviously these people passed away. Or we would have their brains like that. Sorry. So, when you think of brain volume, having a moderate or severe head injury is going to decrease brain volume overall. The longer that you have amnesia, so PTA stands for post-traumatic amnesia, the longer you have post-traumatic amnesia, the greater the chances of having an abnormal ventricle to brain ratio. Ventricles are they're small fluid-filled cavities that kind of cushion the brain. Do we want ventricles to be big or small? We want ventricles to be small, right? Because if we have small ventricles, that means we have lots of brain. Okay? So if we have a high ventricle to brain ratio, that means we have big ventricles and small brain. So length of time that you don't remember after the accident is predictive of brain atrophy. You get more brain atrophy the longer you go without being able to make new memories. Okay? And that brain atrophy is specific to certain areas. The biggest area that takes a hit, as I mentioned before, is the hippocampus. The hippocampus is the part of the brain involved in making new memories, new learning, essentially. So we're not learning as well. How does this have an implication for psychotherapy? Right? The people have a hard time. If you expect them to do their homework and remember it like your other patients, you are wrong. Okay? When I do psychotherapy with TBI patients, we write things down. We simplify. They have their homework and then we do a reminder, either text or email during the week, because they're not going to remember it at the same level as your other clients. Does that make sense, like practically? Okay? So that hippocampus is the part that takes the biggest hit. The next part is the ventromedial frontal lobes, like I showed you. You remember Phineas Gage from your intro psych classes, the guy who had the tamping iron blow through his eye socket? The part of his brain that was damaged was the ventromedial frontal lobes. He had personality change. He could no longer organize his crews. He became very impulsive, very irritable. Guess what happens after TBI? Impulsive, irritable, not good at managing others, not good at social relationships. Okay? This actually goes both directions. A brand new study just came out showing that children who have a TBI are perceived as less competent and less likely to be friendly than their peers who haven't had a TBI. Okay, so kids don't like the other kids who had the TBI. They see them as being odd or weird. Kind of sad. So both sides socially get hurt. Person's not as good socially, and they're also perceived as being socially weird or awkward. Okay? And then the temporal lobes, that's more memory. And this other one I wanted to point out is the amygdala. The amygdala is the part of the brain responsible for detecting fear and detecting threat. So we'll see damage to that, which can lead to dysregulation in threat and anxiety functioning. So people with traumatic brain injury often oversense or over-detect threat. They see the world as more threatening than other individuals, so they tend to get an increase in anxiety disorders that comes along with having a traumatic brain injury. Yeah?
In regard to hyperosexuality through a TBI, what's happening there, Michael?
Did you say hypo or hyper?
Hyper.
Okay. Hypersexuality is pretty rare after a TBI. It actually tends to go the other direction, where they have less interest in sex, not more.
Or they can't say no.
Yeah, so they can't say no. That would be the frontal lobes.
Yeah.
So that would be the impulsivity, the inability to govern their behavior very well. Yeah. So you do see an uptick in pornography use with some cases, just because of that impulsivity, they're interested, the drive's there, and they can't govern the drive, right? But in most cases, we get a lack of interest afterward. Okay, so as far as the atrophy, I just wanted to show you. Oh, sorry, go ahead.
Another question related to that. Do you ever see an increase in physical sensitivity, increased sensitivity to cold or touch? Do you ever see that with?
Yes, it can happen. So that'd be like an autonomic nervous system disruption. And because the whole brain is often taking a hit here, you can get autonomic disruption that goes along with it. Not super common, but can be a side effect for sure. Okay, so as far as the atrophy is concerned, here's a healthy individual. These are from 14-year-olds, a 14-year-old person with a TBI and a matched scan. And you can see the hippocampus is this structure here. It looks like a seahorse. You can see how it's plump and you don't see much black. Black means cerebrospinal fluid. So lots of black means lots of atrophy, right? Here's the person with the TBI. What do you notice? Lots of black. So that hippocampus is taking a hit. They're not making memories in the same way as a typical person. They can still make memories. It's just going to take them longer. It's going to take more repetitions. It's going to take more patience. So let's take a step back for a second. More repetitions, more patience. How does the caregiver often feel? Frustrated. I told you that yesterday. Come on, we just talked about this. Then you start getting that negative expressed emotion going on. What happens to anxiety and depression rates? They're going to go up. So the caregiver plays a big role here, but the caregiver is dealing with difficult things, right? So caregiver burden is often missed in traumatic brain injury evaluations. We should not only be assessing the person who has the TBI, but we should be taking time with the caregiver to ensure both we educate them. This is going to be hard. They're going to need repetition. We need you to be supportive, but to work on coping for them, how to spread the load, how to take time for themselves, right? Or else we're going to get increased depression and anxiety in both the patient and the caregiver. Kind of a double jeopardy situation where outcomes are worse across the board. But just want to make sure that we talk about the caregiver, because the caregiver is really important. We're going to get to some more of the emotional changes in a second. Other things that change are the white matter. So white matter is associated with processing speed, motor movements. You can see again, here's our healthy control. This is the corpus callosum that connects the two hemispheres. Look at how atrophied that is in the individual with TBI. So lower motor coordination, lower ability to do fine motor acts. We have a case right now that we're seeing at the clinic. She worked on an assembly line before her head injury. Cognitively, she's gotten back where she could do her job just fine, but her fine motor skills aren't there. She can't go back to work because she can't put the parts together. So cognitively, she's doing okay, but the fine motor disruption has been a big deal for her. You can see this is a special type of imaging called diffusion tensor imaging, where we look at the white matter pathways. You see that small black blip right there? That's a little lesion in the corpus callosum. Look at how much it impacts. So here's a healthy person. Look how much it impacts the white matter fibers coming off of that. Okay. So one small lesion can disconnect entire areas of the brain from each other, major time affecting motor functions. Okay. Questions about the mechanisms or physiology, what happens after a head injury before we get into recovery? Yeah?
Why does it atrophy?
What's the process? So what happens in the brain is when something gets injured or destroyed, it speeds up the process of cell death. We call it apoptosis. So you get advanced apoptosis, then macrophages, little garbage men in the brain, pull it away. So the cells die more quickly, and then they get essentially taken out by the macrophages in the brain. Good question. Any other questions on the physiology side? Yeah.
Are there any differences in level of injury between ages, like between children and adults?
Not necessarily. So there's a common, I'm going to ruin one of my slides, that's okay. There's a common myth out there that it's better to have your head injury when you're young. That's actually wrong. Traumatic brain injury is a disorder of new learning, right? So the more learning you have beforehand, the better your outcomes are going to be after. Our brain plasticity, science likes to talk about how awesome we are and how plastic our brains are because it's really fun science to do. But truth is, we only know of 2 areas where we can like build neurons, right? So having your injury young hurts you because you don't have as much new learning. You don't have as much you can go off of. So older, up until older adulthood is better because you have better pre-morbid function. Would that answer your question? Okay. Yeah.
What would the difference be in the physiology of injury where you have a stroke versus a feedback injury?
Good question. So in terms of actual physiology, it tends to be very similar. So what happens either after a TBI or after a stroke, just to give you a little more of the direct cellular physiology, glutamate, which is our primary excitatory neurotransmitter, goes gushing out, essentially, trying to activate these cells that are damaged. Call it a glutamate cascade because it overexcites. The neurons excite, and essentially excite themselves to death. And that's when they die, they go into that apoptosis, and they get cleaned out. That's identical for a stroke or a TBI. The lack of oxygen and the cell injury both lead to a glutamate cascade, which can then lead to the removal of the tissue and the overall atrophy. So that part's similar. Where stroke's different is that the cause is due to anoxia, lack of oxygen, whereas in TBI it's due to impact and changes in the cellular structure. But overall, how it ends is the same. Great question. Is that the same question? Same question. Okay, so as far as recovery is concerned, I should have said this earlier. When I say mild TBI, that is synonymous with concussion. Mild TBI and concussion are the same thing. Okay? So when we look at recovery curves, people with concussion or mild TBI tend to get back to baseline, no problem, within 3 to 6 months. We tend to not see long-term dysfunction in people who have had a concussion. In fact, most get better within about 2 weeks. They tend to be getting back to regular-ish levels of functioning, moving there, but almost all get better within 3 to 6 months, can go back to their previous activities, can go back to their job, whatever they were doing beforehand. Okay? Moderate and severe injuries, however, will never get back up to the same baseline where they were before. I love being a neuropsychologist most of the time. Feedback sessions for these kind of things are tough, right? So family members are asking, well, are they going to get back to where they were? And our answer often is no. In fact, I tell my neuropsych students that the best news that we often have for people is it's not as bad as you thought, right? Because they never come see us unless something's pretty bad. So it's not real fun there. Moderate TBI can get some back. Severe TBI tends to be quite a bit lower, never quite getting back to baseline functioning. You'll see here on the x-axis that our scale, this only goes out to 12 months. Typical recovery course for individuals with moderate to severe TBI is you'll get the most gains within 1 year. So between 0 and 12 months, you'll get your most gains, a little more gains between 12 and 24 months, but after 2 years, we don't see a lot of cognitive gains in people who have had a moderate and severe traumatic brain injury. So 3 to 6 months is your recovery time frame for concussion. 12 to 24 months is your recovery time frame for moderate and severe TBI, but we don't tend to see a lot of gains after that time period. Okay? As far as things that you will see, In a concussion, you're going to see slowed processing speed. You're going to see discoordination, balance problems. In fact, balance is our #1 diagnostic test for concussion. So you get the vertigo, the balance. You'll see people on the sidelines doing balance testing with their individuals. The whole count my fingers is just from movies. We don't actually do that. Balance testing is much more predictive of what you see going on there.
I have a question.
Yeah.
If it's their vestibular that actually has some damage on it, what do you recommend for that?
For vestibular damage,
Yeah.
vestibular damage is hard. So oftentimes there are balance clinics, like Utah Valley Regional has a balance clinic, and so we'll go to those type of balance clinics. But as far as like resetting a vestibular damage system, there's not a lot you can do, and it's tough.
And, yeah.
So they end up with nausea, vomiting, that's long term, and can be very impactful. The other thing that some recent studies have shown is that dental manipulations can help. So yeah, dental. So some people that have like temporomandibular joint problems from the injury from getting hit, if they can get their jaw joint fixed, a lot of times the vestibular problems go away too.
Well, they showed damage on the MRI in the vestibular.
So if you're actually showing vestibular damage, sorry. That's not as good as we got. See, being a neuropsychologist is fun, right?
So is that when there's vomiting, projectile vomiting following an injury, is that because of vestibular damage?
Well, it's often because just the brain damage. Vestibular is more rare to actually damage the vestibular system itself. So typically it's just due to cortical damage. It's just your brain is trying to orient, can't do it, so you feel like you're spinning, then you end up getting the nausea and vomiting afterward. I'm a big football fan. I don't know if you guys remember Tim Tebow, because Florida Gators are the best, right? So, second to BYU, I meant. But Tim Tebow hit a guy's, he went back and there was a guy's knee right behind him. He hit his knee, came up, and they showed him on the sideline, and they're like, oh, Tim Tebow, oh, he looks like he hit his head, but he's probably okay. And then 2 seconds later, it shows him just hurling, vomiting. The announcer's like, oh, I guess Tim Tebow has the flu. And I'm like, no, Tim Tebow has a concussion, not the flu. And it turns out he was out for 2 games because of the concussion. But so nausea and vomiting are a big piece of it. And then you get the decreased memory, performance that these individuals often describe feeling foggy, feeling like they're in an emotional and mental fog. That tends to lift after 3 to 6 months, but memory, attention, processing speed, that's all part of that fogginess that they feel during that time. Okay? Other long-term effects from concussion, again, we're just talking about concussion here. Long-term, we typically see nothing. After 3 to 6 months, people get back to baseline, can do pretty well. They're at increased risk for future concussion, but they tend to be able to go back, fulfill their social roles, fulfill their family roles, fulfill their work roles, just fine after 3 to 6 months. Okay? That's cognitive functioning. Emotional functioning can persist a little longer, like emotional changes. So these individuals will often get increased irritability, increased depression, and increased anxiety symptoms. That can persist longer than the 3 to 6 months. In fact, one of our biggest predictors of poor cognitive outcome is poor emotional outcome. So the people that are having persistent depression and anxiety symptoms oftentimes will have persistent cognitive symptoms that go along with it. So they're kind of intertwined, but the emotional tends to last a little longer than the cognitive as far as the difficulties are concerned. So much so that we get increases in risk for psychiatric disorders. So if you think of the typical depression population being about a 20% risk, after a head injury we're between 20 and 30% risk after a concussion. Anxiety disorders, we're at about 15%, 14%. After head injury, we're 25 to 55%. Right, so big upticks in depression, anxiety, and even PTSD and acute stress disorder, though our research is really precise here. Somewhere between 3 and 48%. Small sample sizes in the studies account for that huge variability. We need some bigger sample size studies looking at PTSD, which we just don't have yet. And so, take-home message for concussion. 90 to 95% will have a full recovery, most within that 3 to 6 month period. When they're fully recovered, can do whatever they were doing before. There is a small subset that have continued emotional difficulties, about 5 to 10%. Those may persist longer term. And the emotional stuff, if you use like self-report measures, you're going to do better even than neuropsych measures for the emotional side of things. So that's where you can get. Now, as far as that 5 to 10%, what predicts worse outcomes after head injury? Well, I have a very simple slide that will show you exactly what predicts poor outcome after head injury. Right, there's so many things. The people who aren't recovering well, the number one reason they don't recover well is litigation. They've been in a car accident, they're suing the insurance company, their symptoms don't get better. Okay? That's the number one predictor of poor recovery after concussion. Number two predictor tends to be depression and anxiety, psychiatric conditions that come along with it. Okay? Then you get other things like expectation, or even physician iatrogenesis, where the physician's saying you should be doing poorly, and so they start doing poorly, right? So it's very complex and complicated, but the take-home message is most get better, 90 to 95%. How about after moderate and severe? Well, remember, they don't get back to baseline after moderate and severe TBI. So you're going to see a wide range of cognitive effects. Poor problem solving, increased irritability, increased impulsivity, poor memory is going to be a big piece of that. Personality change, okay? Lots of things that can impact relationships. So because they impact relationships so strongly, couples therapy is often needed to help the couple work together. We find divorce rates tend to go up by quite a bit, more than a quarter, after people have had moderate and severe traumatic brain injuries. Between the caregiver burden and the distress that comes into the relationship, it's a big piece. Yeah, change of roles, suddenly becoming a caregiver, personality change, it's tough. It's tough. What I often teach my students is that whatever was there before, you just turn up the amplifier on it. So if the marriage relationship was rocky before, you're going to turn up the amplifier on that. If the depression or anxiety were present before, turn up the amplifier. If they had a good relationship, then one spouse tends to step up a lot of the time. It tends to, I wouldn't say make the relationship better, but they tend to work through things more. There's one exception to this, and that's when the male tends to be more like physically, not necessarily physically violent, but dominant or irritable before the injury. I've had several cases where they become apathetic and the wife's like, this is the best we've been in 20 years. But it's happened more than once. So, sometimes head injury is good in that regard. Other things, go ahead.
I have a friend, his wife was a ER nurse,
Oh, geez.
and she had the accident, and says their marriage is actually better because being an ER nurse, there's so much edge.
Mm-hmm.
It's taken off the edge, so there's that is lightened. So even though it stepped up the other way, the emotional softness that's happened has kind of like improved the relationship with the whole family.
Fascinating. Yeah, so we see that on occasion, most of the time with the male, not with the female. So that's interesting. So other things, I mentioned the physical difficulties, I've talked about the fine motor problems. One thing to watch is fatigue. Individuals with moderate and severe traumatic brain injury and in mild soon after tend to have high levels of fatigue. They'll fatigue more readily than other people. A 50-minute psychotherapy session with a moderate or severe TBI can do them in for the day. Okay? So take-home message here is we need to do more activity pacing with them. 15 minutes on, 5 or 10 minutes off. 15 minutes on, 5 or 10 minutes off. If they reach fatigue, it tends to blow them up for the rest of the day. So if we can teach them to pace their activities, they actually will be more productive by taking more breaks. Because they're not out of gas by the end of the day where they can't function anymore. So the activity pacing is a big piece of helping people who have had a traumatic brain injury. Okay? And then as I mentioned before, the behavioral and emotional changes tend to be the biggest piece of this for family members. The person isn't the same anymore. They're not able to plan and organize and do the things they could before. So there's an extra modicum of patience required by the caregivers and family members that are hard. And in many cases, we get outbursts. We get changes in appetite, the sleep. People either get hypersomnia or hyposomnia. It can go either way. You get upticks in depression, anxiety symptoms. All of that comes along with it, just kind of making this pot of emotional stew that's difficult for people to come out of. So our role then as psychological professionals is just to make sure we have our eyes on that and to provide treatment. But sometimes the 50-minute session isn't the best way to provide said treatment, right? Sometimes we have to break it down and do 2 shorter sessions in the week instead of 1 long session. Sometimes we gotta do some individual and some couple. There's lots of ways that we have to adjust our practice to account for these things, writing things down.
How effective is traditional psychotherapy then in mental health management?
Great question, not as. We don't have like specific rates, but we know it's not as effective. Part of that's because they can't problem solve as well. Like if you're doing a CBT type treatment, you're trying to get them to work through their automatic thoughts. My common experience is, like they have no idea what I'm talking about. I'm doing psycho-ed with them and they just look at me like I'm nuts.
So is
Right?
it better to do it than not?
Still better to do it than to not do it, but oftentimes supportive psychotherapy, emotion-focused type psychotherapy tends to have a better impact than trying to do a more cognitive type therapy that requires insight. The supportive and emotion-focused tends to be a little better than that.
Wondering about medicine like gabapentin or supplements like omega-3s, what's
Yeah.
the research on that?
So gabapentin is kind of an elephant gun. It can bring things down, reduce seizures, so we do get that oftentimes being prescribed to these people, but it can kind of have an emotional numbing that they don't like. So oftentimes they'll be prescribed, and I hate this, benzodiazepines to take the edge off the anxiety. New research is just coming out though showing benzos, particularly in older adults, are leading to increases in dementia rates. So you add a group that's already at increased risk for dementia, you start throwing benzos at them, yikes, right? So SSRIs would be our most common medication with the least side effect profile that are used. But you often get anti-epileptics, kind of like the gabapentin, but more often like the trineptal kind of class, to reduce seizure incidence, but also bring down the emotional.
I just wanted to make a quick note too. My son experienced a severe brain injury when he was 10. He was kicked in the head by a horse. And then we had a suicide attempt he survived a year and a half ago. And so we've got the anoxia from that. And so, we're actually trying to find a way to separate the cell death post this injury versus that injury. And so just maybe be aware there is that increased suicidal risk.
Yeah, the depression symptoms definitely
Yeah,
creep up.
and it can, we did some research. I work with brain injury association as well. But yeah, they found it can go from 15 to 33 years.
Yep. Yeah, and that's the emotional piece I was speaking of. It tends to last much longer than the cognitive piece. And the big predictor of return of success is return to previous roles. So if we get people into jobs, if we get people into family or emotional roles where they feel useful, it tends to improve. And then the depression symptoms tend to not go away, but go down a little bit.
And the schizoaffective piece too is something that's, and something, I work with vets, and that's something that I see, that piece too. If they have, a lot of them will develop schizophrenia post-injury.
Yeah. Thank you for sharing.
What about that constant happy state? That seems to be quite the opposite of what we've been
Yeah.
discussing.
So these two I should make a note of. So inappropriate laughing and crying, we call it pathological laughing and crying. It's an ICD-10 diagnosis. What happens is the brain, the bulbar system, which you guys don't really care about, gets disrupted, and so people don't know how to regulate their autonomic, their laughing and their crying. So they'll start laughing at inappropriate times, and they'll start crying out of nowhere. You ask them, are they sad? And they say, no, I'm just crying. Are you happy? And they say, no, I'm just happy. Like, my face is happy, affect is happy, but they're not actually happy. And so same thing with that constant happy state. It's more of a constant happy affect than it is an actual happy state. And so they just can't regulate their affects. They'll kind of look like they're smiling, but they're really angry at you. So it can be a little bit tricky.
I had an experience. So I have a sister-in-law 5 years ago. She was out running and got hit by an SUV.
Oh my gosh.
And amazingly, she survived, but she had brain shearing and a stroke. She has recovered like amazingly. She's a walking miracle. She went through these phases of extremely rude, swearing, hating everyone. It was like she was going through her adolescence again, and then she's moved out of it and is in such a calm, like almost back to where she was. Her personality's tweaked, but she's actually a more like extroverted person now and outgoing and but she's like, she even explained through the process how she was identifying how her behaviors were affecting other people, and so she really started working on changing these things that happened through the brain injury, and it's been amazing to watch her progress.
Well, that's fascinating. I mean, a lot of people, again, there's varying levels of severity. Not everyone has the insight to do that. So that's fantastic that she has that level of insight to do that. So I'm going to skip ahead for a little bit to get to the case. Everyone cool with that? The case is kind of interesting. So the case is someone I saw twice. We saw them once when she was 13 and once when she was 15. And kind of the take-home message, I'm going to jump ahead here. Take-home message is the huge role that social and emotional support plays in TBI recovery. Okay, so this is a 13-year-old who made a bad mistake. She got into a car with an individual who was intoxicated. Okay, 2 bad mistakes, and she didn't wear her seatbelt. Okay, between those 2 things, she ended up unconscious and intubated at the scene. Her Glasgow Coma Scale score was 7. What does that put her as far as range is concerned? Okay, it puts her in severe, but this is interesting, just a little FYI. When you have a T after a Glasgow Coma Scale score, it means they were intubated at the scene. What does that do to their speech score? Makes it a 1. So she's actually a moderate, not a severe, because that 7T indicates her speech score was a 1 instead of, it could have been higher. But she was intubated. So she was in acute care rehab where she wasn't following commands. I saw her soon after that. She was following commands when I saw her. Now, it was fascinating because I saw her on a rehab floor, and her family had bought non-refundable tickets to Disneyland for a month later. You've never seen a carrot dangled before a 13-year-old quite like that before. Her rehab was amazing. She worked super hard. She had awesome family support, and so she really cranked at her rehab. So she's a bit of an unusual case in that regard. But I guess one take-home message is if your child has a head injury, dangle Disneyland. It's effective. Other things about her: birth and development, not remarkable. She was bilingual. The research on bilingualism actually suggests increased cognitive reserve. And so you can have a head injury and not take too big of a hit if you're bilingual. Kind of interesting. Other things, she was an honor student, played the flute in the band, was the type of kid that you'd want as a parent, right? She came in and she was super, super anxious. And as the testing got on, I'm like, why are you so anxious? Like, I'm trying to probe that a little bit. And turns out her goal in life was to become a lawyer. She thought, she'd been kind of misinformed, that my evaluation was going to determine whether or not she could become a lawyer in the future. So she was just petrified that I was going to tell her no. So once we clarified that wasn't the purpose of my evaluation, things improved quite a bit. Okay, but she was initially very anxious, right-handed, tried so hard. Like, this is a measure of effort. She got 99 out of 100 on her measure of effort. She really was working hard. Great girl, someone that you like to have there. But her accident was quite severe. Let me show you an example. So this is a figure we have them trace, and then we have them recall it from memory half an hour later. Okay? But we don't tell them we're going to have them recall it from memory. We're like, oh, trace this little thing. Aren't we nice little fun people? Oh, you remember that thing we saw earlier? And then they leave. Right? So here's her copy. Sloppy. For a 13-year-old, most will do a lot better. You can see she's missing entire lines. She shifted that whole thing upward. That's with it right in front of her. Right? This is a copy. Here's her 30-minute later performance. Memory takes a big hit. Okay? Here it is when she was 15, 2 years later. Here's her copy. What do you think? Improved? Yeah, we see, remember, 2 years, we tend to see quite a bit of improvement. While improved, this was still in the moderate, the impaired range for someone her age. Still not really good. A lot of sloppiness, a lot of overlap, visuospatial dysfunction, not straight lines. I know a lot of you are thinking I would fail that. But when you're copying it, you find you do better. Okay. Here's her 30-minute. Go ahead. So she's getting the gestalt, but what do you notice about the details? Her details just aren't quite there. So really struggled there. Our testing, what we ended up finding is she had persistent nonverbal and visuospatial difficulties. She was quite a bit slower, like her processing speed was slowed down, her language was slowed down, but she still had really good verbal memory. She could remember things. Okay? Remember how I said she was on the honor roll when she went in before her TBI? 2 years later, this girl was achieving a 4.0. Okay? She had incredibly strong parents who were working with her, doing rehab with her. When I show you her scans in a second, you're going to be amazed she was having a 4.0. But here's the trick. She was taking 8 hours per day on her homework. She'd get home from school, start her homework immediately, and work until midnight. And then she'd go to sleep. Highly motivated, highly dedicated, but what do you say to a 15-year-old at that point who wants to go to law school? Right? Look at her scans. So this is her scan right after the injury. You can see it's neurologic convention. They make it a pain for us. Right is left, left is right. It's as if you're looking at me and I'm laying down, if that makes sense. So that's the right side, that's the left side. You can see temporal lobes, hippocampus, new learning. Got hit, but watch her right hemisphere here. See this big contusion going up, and it goes all the way up into her visuospatial cortex, her parietal lobe through here, and both of her frontal lobes. Here it is after 2 years. Remember what I said about ventricles? Big ventricles equals small brain, right? Look at how much brain matter she lost. Think she's going to be a lawyer? How do you handle that case? Right?
Well, doesn't other parts of the brain take over?
They can. So that's the plasticity piece, but that's why you want to be, the better you're functioning beforehand, the better you'll function after. Right? So she was functioning pretty well. It took her a long time to do things. So we kind of talked about accommodations with her. We didn't want to crush her dreams at 15 though, right? So we tried to give her support, tried to work through her, but we tried to be realistic as well. This is going to be really hard, processing speed is going to be slow. I haven't seen her since, I don't know what ultimately happened. But she's an interesting case of how emotional support, she didn't get into depression, anxiety, and how kids can function, kind of give you some brain imaging with it. Question me, because I like questions. And we have like 3 minutes.
Is that white, I'm sorry, the
Yeah.
white circle?
Yeah.
Is that part of the scan or?
Right here?
No, although the bright white around?
Oh, that's the skull.
Oh, okay.
Yeah, this is a CT, not an MRI, so it's an X-ray. Good question. That's Henry. Go ahead. Yeah.
Yeah, so do the hospitals still have those records years later?
Yes.
Do
With-
require you to keep that in your stuff?
Yeah, almost all hospitals keep that stuff for long term.
Just 7 years?
7 years is the minimum, but most will find it, with the electronic medical records, most can find it from way back. If you're getting into paper records, it's going to be trickier, but if it's an electronic system like PACS or Syracuse, those are the kind of things we've used, they can find them.
I had a question about the TBI that happens from explosions, all the vets that are, I have a brother that has, he's disabled because of the TBI
Yeah.
shot from multiple explosions, but do they react the same way as any other?
Yep, so this was a huge thing of research after the Gulf War, right? Because
Yeah.
we're getting all these blasts, and they're actually getting their TBI from the airwave coming off the bomb, not from actually getting hit by something other than the airwave from the explosion. The blast injuries, what we found over about 10 years of research now, react the same as other head injuries in the end. Initially, we thought they'd be more diffuse, but they're not. They tend to get the frontal lobes and the temporal lobes just like the other ones. Tend to get the same irritability, anxiety, depression. So that was a hot area of research that's kind of come down because they look really similar.
Yeah.
Good question.
Tell us about this traumatic injury we're talking about, but for non-traumatic, maybe chronic or time injuries, or people that may have brain damage due to more prolonged things. What is the insurance coverage typically for that kind of testing?
Great question. So neuropsychological testing is getting covered less and less by insurance companies. If we can show them an identifiable medical event, it's easy to get. If we can't show them an identifiable medical event, it becomes harder and harder. Our clinic tries to fill that gap. We offer $400 evals that will slide the scale down to $100 over at the comprehensive clinic here. But otherwise, you're talking $1,750 to $2,400 an eval. So they're really expensive. And insurance is becoming less and less of a player in this game. Frustrating. Frustrating.
Tell me about your current, or maybe some new research on the horizon for imaging that shows more of it?
Yeah, so our current study that we're most excited about, we're taking people acutely after concussion within 3 weeks, imaging them and doing EEGs on them as well. Then we're bringing them back 9 months later to look at fully how the brain heals and then what the predictive factors are of the brain healing over that 9-month period. We're still collecting, so I don't have data on it yet, but we're excited about it. We've got 50 people, 50 concussed and 50 controls so far, and we're still collecting. So, great question, thank you.
You talk about this 13, 15-year-old girl in rehab. What's this rehab?
So rehab, you go into a rehab hospital and you're required to do speech, physical therapy, which tends to be the lower legs and like torso, and occupational therapy, which is fine motor skills and ADLs like feeding, bathing, toileting, that kind of thing. So they're required while they're in the rehab hospital to do that for multiple hours each day, and then they move on speech therapy. Did I say speech already? Speech is a part of that as well. So then psych gets brought in often on the back end. Other questions, please come see me after. We're out of time. So thank you very much, and then come and see me if you have more questions.